Hello and welcome to Sleep Review's webinar, Ask Us Anything, Inspire Medical Systems, Inc., makers of upper airway stimulation therapy for obstructive sleep apnea. I'm Sri Roy, editor of Sleep Review, and I'm here with two esteemed panelists. Colin Huntley, MD, is an academic sleep surgeon. He has dual training and board certification in both otolaryngology, head and neck surgery, and sleep medicine. His clinical and research interests surround alternative management options for obstructive sleep apnea. Dr. Huntley's institution began doing upper airway stimulation in 2014 and currently has the highest upper airway stimulation volume worldwide. Deborah Goss, MD, is a pulmonologist in Hackensack, New Jersey, and has been practicing for 16 years. She graduated from Creighton University School of Medicine in 1997 and specializes in pulmonary disease, critical care medicine, and more. For more than 2 years, Dr. Goss has been evaluating, activating, and managing upper airway stimulation in her patients, including more than 80 patients to date. These physicians are here to answer your questions about Nspire. Many of you submitted your questions in advance, which is excellent as it allows us to begin today's event with several of the most frequently asked questions first. We also encourage you to submit your questions now via the Q&A box on your screen. Dr. Huntley, to start our discussion, could you provide the audience a short refresher on how Nspire works to treat patients with obstructive sleep apnea?
Sure. So basically there's three components: a respiratory sensor that's placed in between the ribs, a internal pulse generator, which is a pacemaker-like device that sits on the chest in the subcutaneous tissue above the pectoralis muscle, and then a electrode which sits on the protrusor branches of the hypoglossal nerve. When the patient activates the device at night before going to bed, there's a delay to let them get to sleep, and then after it kicks on, the respiratory sensor senses the change in pulmonary pressure, which sends a signal to the IPG, which thus in turn sends a signal to the electrode to stimulate the nerve, and the tongue will contract and move forward, and we hope that there's linkage to the palate as well to provide multi-level opening of the upper airway.
Fantastic. As a sleep surgeon, you probably see a lot of patients who are looking for alternatives to Cpap. When discussing alternative treatment options with these patients, how do you talk to them about Nspire?
Our basic approach is we use drug-induced sleep endoscopy as a main portion of our practice to identify where the upper airway obstruction is. That's a procedure where we go to the operating room, the patient is placed under sedation with propofol, and then we evaluate the upper airway with a flexible bronchoscope to assess where the obstruction is occurring, whether it be at the palate, the oropharynx, the tongue base, the voice box, and what the character of it is. Based on that, we have a discussion about what treatment options we have. We've certainly progressed a long way from a UPPP, which is not a great operation. It doesn't provide significant improvement in the AHI. So we have other palate surgeries which are well described in the literature and offer significant improvement. And we have other interventions at the tongue base, at the hypopharynx, and then upper airway stimulation is just one of a number of options we have. We know that lots of patients out there have a hard time tolerating Cpap, and we can do a lot to help that population.
Dr. Goss, you've helped many of your patients with Nspire. How have you been able to effectively incorporate this therapy into your practice, and how is your care team organized to help patients with Nspire?
So we have a very large sleep practice with a lot of patients that are already on Cpap. Excuse me there. With the Cpap, some patients are very happy with it, and some patients need to try a new therapy. Of the patients who are happy with it, we'll ask them, do you want to stick with Cpap, or do you think you need something that's easier to travel with, not as uncomfortable on the face, anything that you would feel that would be more comfortable and more normal for you to use at nighttime. And a lot of times they will say that they may be happy with Cpap, want to continue, or they may want something new that's just that much easier to travel with and to use every night and seems more comfortable to them. without having something on their face. So patients will usually approach us and say, look, I've had CPAP for years, it's been working out okay, but I think I'm ready to try something new.
Great. Dr. Huntley, what are the most relevant findings from clinical publications so far?
I think the most telling data point is how well this therapy is tolerated, and also the low complication rate. So when we look at some of the latest data measured at a year, patients are using this for almost 6 hours a night. And the interesting thing is each one of those patients had a hard time tolerating CPAP, whether that be a comfort issue, a excessive pressure issue, a claustrophobia issue. So it's a very well tolerated device. And then when we look at data related to either surgical complications or device related intolerance, the rates are very, very low. There's minimal to any issues with hypoglossal nerve paresis, very, very low infection rate, and then the device is tolerated well where it doesn't disrupt sleep and does not have issues with swallowing or speech issues. Then we can certainly talk about outcomes in terms of control of AHI and symptoms, but we may want to kind of hold that for later on as well.
Yes, we do have some questions that are already coming in about that. Dr. Goss, question for you. Which patients are good candidates for Nspire, and what are the exclusion criteria for its use?
So yeah, I have to hold myself back from saying everybody should have an Nspire because I see so many sleep patients, but there are some clear indications for who should have it. First of all, it's for adults with obstructive sleep apnea, and the obstructive part is important. You do not want to have a patient who has more than 25% central events because they won't benefit from the device. They simply will be unhappy with it. It won't be effective for them. The guidelines do go by AHI and not RDI. So that's an important distinction to know. You do want someone with an AHI of at least 15 events per hour. I know a lot of sleep physicians are used to looking at RDIs, but you want to check the AHI. Their weight is important. Someone can be a little bit obese, but you don't want someone overly obese that they would not benefit, and there's criteria for that as well. The criteria that they fail CPAP doesn't necessarily mean that they have to do poorly with the CPAP. They can be doing great with CPAP and they just feel this is not the right option for them and they want to switch to a new machine or a new device. That's an important thing to know. At the end of the day, you want the patient to be happy and benefiting. So there's some patients who may not be able to have a device. If they have trouble with speech or swallowing, like I did just a minute ago, they may not be the best of candidates. If they have a chronic stroke and dysphagia, that would not be a person to put this device in. Interestingly, all head and neck surgeries are not considered a contraindication because we have had patients with UPPPs who've done very well with Nspire devices. So that's something you may want to talk with the ENT you work with. I'm sure Dr. Huntley will comment in a minute about that. People who are in law enforcement, you have to know which hand is the hand that their firearm is in because you do not want a gun to recoil into the device. People who do professional diving, you have to know how far down they're going to travel, what their distance is, because the device is only rated for about, I think, 100 meters down. MRI compatibility is not an issue with our newer version of the device. It was at one time, but there are still some MRIs that you would want to discuss with the company, whether a patient would be a good candidate or not. And they can actually have a pacemaker. Patients with a permanent pacemaker in the opposite side can have an Nspire device, and they do very well, in fact. So once you have someone who meets those criteria, the other thing you want to ask yourself is, are they capable of pressing that button every night and committing to using the device and doing the pre-op and the post-op care and the follow-ups? Because if you don't think they're going to actually press the button and use the device, then that would be a reason in and of itself not to give it to them. If they just want to fix me with a surgery and send me home, then it's not going to work for them. They actually have to physically press that button every night. So they have to be committed to doing that. And they have to understand that they're still going to need to do something. It's not like a pacemaker of the heart where you don't have to do anything once the pacer's put in there. There still is quite a bit of involvement they have to do. And once that's understood, then I think at that point, you do need to do the drug-induced sleep endoscopy or DICE procedure, which is a very simple same-day outpatient procedure. It takes all of 5-10 minutes. And then if they pass that, then they'll be able to be further evaluated by the ear, nose, and throat surgeon to move forward. And I think maybe Dr. Huntley would want to add to that.
I agree with everything Dr. Goss said. The two comments I will make is, well, three comments. The one thing I particularly agree with is that this is something that patients need to commit to, and it is something they're going to have to do every night if they're going to get if they want to get benefit from it. The other two comments I'll make are for law enforcement or military members or patients who skeet shoot or shoot firearms frequently. This can be done on the left-hand side, so we can implant it on the left side if they use their right side to shoot. The other thing we've done is just simply move the IPG more medially or more toward the sternum in patients who wanted it on the right-hand side but still shoot. Like, I've actually just drawn out in the preoperative holding area where the buttstock goes on their shoulder, and we just avoid that area. So that can still be done. And the other comment is prior sleep surgery, there's, I think, 3 publications today. We put some data out, and then there was 2 other follow-ups, I believe. And there's no decreased effectiveness with this intervention in patients who have had prior UPPP, other palate reconstructive interventions, maxillomandibular advancement, or any kind of tongue-based reduction. So prior sleep surgery does not preclude this.
And I believe we have a video file of the DICE procedure and kind of what it looks like. Dr. Huntley, would you be able to explain that difference in that video, what people are looking for in that DICE procedure?
Sure. So just to orient everyone, it was a view of the nasopharynx looking down at the palate, and on the, I guess, the top part of the video image was the back wall of the nasopharynx, and on the bottom part is the soft palate. So you're looking actually at the superior aspect of the soft palate. The video on the left shows anterior-posterior obstruction at the velum or the soft palate, which just basically means there's an obstruction where at the level of the soft palate where the soft palate is collapsing from a front to back position. This, we think, is a good, or at least the FDA says this is a good option for implantation of patients. The video on the right shows more concentric collapse, which is more of a funneling motion where there's concentric obstruction at the palate and down into the oropharynx. The data that's out there suggests that complete concentric collapse at the soft palate is not a good predictor of candidacy for upper airway stimulation, and thus those are the indications from the FDA and the insurance company. The asterisk with that statement is that study included 6 patients, so it's very limited data. What we're starting to think now, and this is more of an academic discussion, but as the indications from an insurance standpoint and FDA standpoint and Medicare haven't changed, but what we're starting to think now is that lateral oropharyngeal obstruction, so the level of the tonsils and then further down, are actually more predictive of lack of response. But that's, I guess, a discussion for another venue.
Dr. Goss, would you like to add anything about DICE?
Yeah, so when we do the DICE procedures, generally it seems that 3 out of 4 patients will be perfect candidates, and there's that 1 out of 4 that somehow will either be concentric or it just seems like it's almost concentric and doesn't look like they would be a good candidate. And patients have their hopes set on getting this device. So when they come in for the DICE procedure, their hopes are very high. So after the procedure, if they're a good candidate, we'll usually tell them, hey, you know, things look pretty good. We think you'll be moving forward with your procedure. If they fail and they get complete concentric collapse, I don't like to say to them, you're not a good candidate right off the bat, because it crushes them too much. Their hopes are so high. So what I tell them is, not now. Why don't you go back and lose some weight? Why don't you go back and work on some throat exercises, maybe see the ear, nose, and throat doctor, and we'll circle back around after you've lost 20 or 30 pounds, and we'll see what happens. Because they need to do that anyway for care of their apnea. And rarely we will have patients either with, they'll have a UPPP or they will have significant weight loss, and they'll come back to us and they'll be AP. But, you know, it's hard to tell somebody immediately post-procedure, guess what? I know you really wanted this device. You're not going to get it. So we try and tell them instead, not now. You're not a candidate right now, but let's see what we can do to make your apnea better, and then come back to that.
Very good advice. Dr. Goss, do you have any kind of like decision tree or any information about when should you as a physician choose Inspire over standard treatment?
So standard therapy is always the best way to start with patients because they're new to the whole idea about having obstructive sleep apnea and what it means. And it also gives them the discipline of doing something every single night. And they can see, you know, how that is involved and changes their lifestyle. And they learn how important it is to them. And you know, I'll tell them, look, insurance is paying for all this equipment for you. Do you think they're doing it because it doesn't work? You know, clearly you need this to treat your underlying comorbidities so you don't have further complications as time moves on. So patients, you know, will start with that, and then and then there are patients who are seeking other options early on, even before they have their first trial of Cpap. They go, I know all about this. I don't think I want to wear this mask. I want another option, and they know about the Inspire and they know about dental devices and all of those things. We'll explain all the different options to them. But we usually insist that people at least try the Cpap first before they do anything else, the dental devices, the surgeries, any other things, partly because it will be covered by insurance right off the bat, and the other just to get a sense of if it would work for them or not, because there are a lot of patients who think they can't and suddenly discover they can. So it's always good to start with that. And then I have patients who I've had for years with Cpap, and they come back to me and I said, do you like your Cpap? Yes. Are you happy with it? Yes. And I'll say, well, you know, in all fairness, I do need to let you know whenever there's something new in medicine, and this would be an option, and you would be a candidate. If you're interested in it, I'll give you literature. They have a beautiful website you can go to. And if you decide you want to do it the next time you come see me, or you come back, you call me and say, hey, I want to do this. I said, otherwise, I'll just continue your Cpap. And that way, the decision is in their hands. They can read more about it. They can ask their friends. They can Google it. You know, they're going to Google it. And then they can come to a decision of, you know what, I do like this option. So just because someone's doing well on Cpap doesn't mean I wouldn't offer it to them. And just because someone's doing poorly on Cpap doesn't mean I jump and offer it to them right away. They really have to be a good fit candidate. I think Dr. Huntley mentioned it. They have to understand that this is something that takes some discipline and you have to do it every day. It is more comfortable for a lot of patients, and it seems easier to hit a button than to put the mask on, but it still requires discipline.
Fantastic. I think the next question that we've gotten is about Inspire compared to Cpap, and we have a video of Inspire, well, how it looks with no stimulation, and then how it looks with mild stimulation. Would either of you be able to explain what is in that video of the mild and the no stimulation video?
It's like a sedated endoscopy video of someone with their upper airway stimulator device being activated, or at least on, and the panel on the left at the level of the tongue base, you're able to see the epiglottis and the larynx, and then the panel on the right. So this slide that's up now, on the left two videos or films, the leftmost one is at the level of the tongue base, and you can just see the epiglottis in the distance, and then the second one over is at the level of the palate, and the soft palate on the bottom part of that video. And then on the right-hand side, the third window over, you're seeing the alleviation of obstruction at the level of the tongue base with the contraction of the tongue and opening up that level of the upper airway, and then at the level of the palate on the right-hand side. So you're able to see multi-level relief of obstruction with a lot of patients with this device.
Great. Dr. Goss, how effective is Inspire compared to Cpap?
So compared to Cpap, Inspire, I think they're equally effective. The difference is that people tend to use the Inspire more because you need to use the Cpap at least 4 hours a night to benefit from it. The Inspire, people tend to use it the whole night. So I don't know that we have the data for that yet. I know there's a registry that's up and running to see if that's in fact true, but at least anecdotally, patients seem to really, really use it more and enjoy it more. So I know in the studies we initially did, patients did say that they had high satisfaction with it. I don't know that there are studies in Cpap that have such high satisfaction. And patients have said that they use it. Adherence hasn't been as much of an issue with Inspire as it has been with the Cpap. If I could circle back to what we just did a minute ago with the with the stimulator video. On that video, you notice that you could see the muscle move. And when patients wake up in the middle of the night, if they still have their Nspire turned on and they do not pause it, they will slur their speech. And if they're trying to drink water, they'll spit it out. That it is actually stimulating the muscles. The muscles are moving. So it may seem subtle on the video, but if patients forget about it, they will remember the minute they try to talk or they try to swallow something. So it really is a stimulator. Some patients initially will feel that when the stimulator turns on. Most of them, the stimulator will, when they turn it on, has a pause, kind of like a ramp does in Cpap. It won't immediately turn on when they go to sleep. It'll wait until they're in sleep, and then it'll slowly, gradually turn itself on so that they do not wake up and notice it. And most patients will sleep through it the whole night. But if they are awake when it stimulates, they know this. They feel it in their throat. So it's something that you have to educate them before it happens so they know about it. And then and it's something that they usually get very used to very quickly. Dr. Huntley might want to comment on that too.
Yeah, the only thing I'll add, I agree, is that it does not cause disruption of sleep. So the vast majority of patients don't complain of discomfort, and they don't find it waking them up in the middle of the night. There's also doesn't seem to be residual issues with speech or swallowing issues after the device is turned off. The other evidence to some of that point is that there's published data looking at arousal indices and actually looking to see if there's arousals associated with stimulation, and it does not seem to cause arousals on PSG studies.
Great. Dr. Huntley, how safe is the Nspire procedure? Have there been any side effects observed?
So comparing it to other surgeries or implanted devices, it's very, very, very well tolerated. The latest paper that has the highest number of patients was around 1,100 and had both surgical related and device related side effects or complications listed. Very low rate of hypoglossal nerve paresis. I think it was 0 events at the 1-year follow-up rate. No issues with infection at that 1-year follow-up. No issues with speech or swallowing, and then relief of any surgical related discomfort very quickly. A lot of patients are able to go home and not use any narcotic pain medications. They're able to get away with Motrin and Tylenol and do quite well. And then from a device-related side effect profile, it's well tolerated. Like we just said, it doesn't seem to cause discomfort or issues with either nerve discomfort or numbness, tingling, or pain in use. And it does not cause residual speech or swallowing issues after the patient wakes up in the morning and turns it off.
Dr. Goss, what is the recommended follow-up, and should it be done by the sleep physician or by the surgeon who implanted the device?
Well, each patient has to follow up with the surgeon just for surgical post-op care. So all of our patients are seen again by the surgeon for a follow-up visit, just to review the site and the implant itself and any surgical issues. After that, they follow with us. We activate the patient, which means we do the initial turning on of the device once everything is healed. We usually don't turn a device on until everything is healed so that patients are very comfortable when it gets turned on the first time. Then we train patients how to use the device, and they can actually self-adjust the stimulation. And kind of like you would turn up your Cpap, they will turn up the voltage on their device as they're comfortable with it. And we will coach them to try to get to a level where we feel that the apnea is very well managed. So when they reach a point where it seems like they have good daytime energy, they feel as good as they did with the Cpap, there's no snoring, at that point they will need to have a sleep study to confirm the optimal setting for their device. So that usually happens several weeks after it's activated. Once we confirm that, then we will follow them for any tolerance or issues. At 10 years, they will need a battery change. So there's periodic visits to check on the battery function. And also we will follow them with phone calls. We have a nurse navigator who actually follows them through the whole system. She will coordinate them from the minute they say they're interested in the device through their DICE procedure, through their implantation, through their activation. She'll call them the very next day after it's turned on to see how their first night went. They will call her to troubleshoot things like the battery didn't work. They had to, in their remote control, and they forgot to put new batteries in and such, because that's actually a separate battery in the remote control than in the device itself. The remote control has just regular over-the-counter batteries. And she'll help them troubleshoot those kind of issues. And again, they'll have follow-up with the sleep physician until they're optimized. And then after that, we will see them just periodically. Usually it's once someone is established, it would be 6 months and yearly.
Great. Dr. Huntley, would you like to add anything about follow-up?
No, I agree. In our practice, we tend to follow patients and do the activation and optimization. So it's different practice to practice. But then, I mean, I agree with everything Dr. Goss said. It's generally follow up every 6 to 12 months to ensure that they're tolerating it well. There hasn't been any change. Obviously, if someone puts on 20 pounds, you may need to make some adjustments. And it allows us to assess the battery life. So as we're getting close to that 10-year mark, we can plan to change the battery out.
Dr. Goss, how do you titrate Inspire?
So initially, we have to titrate to patient comfort because patients do have to become comfortable with the device. It's kind of like wearing glasses or a hearing aid. You can't go from not having anything to having it and being completely comfortable initially. So there is a bit of a learning curve. So the patients have a device where they can turn up or turn down their voltage depending on how comfortable they feel. And they have usually a couple of click range. Usually it's a 10 click range. They can go up or down to comfort. And we will encourage them to do it initially when they come to see us the first time. We will find out what the threshold is for their comfort and what's the threshold to actually see the movement of the tongue forward and that the device is actually opening up the airway. So that's determined while they're awake. So they're sitting, they're very comfortable. We're like, you know what, we're going to turn your device on. They sit there and we're like, you're going to feel a little tingle, and we press the button. They feel it. They open their mouth up. We look to see what their tongue is doing. And was like, okay, how was that? Was it comfortable? Do you think you would be okay with that at nighttime? And we walk them through it. Then at follow-up visits, we encourage them to get to a voltage that we think was going to work to control their level of apnea. Some people have very mild apnea, they're 15, 20 events an hour. Some people are more the 30 or 40. So we'll work with them until we know that clinically they're at least achieving good daytime functioning and their sleepiness is gone and that their nighttime snoring is gone. So once we've hit that threshold, then it's time to move into the sleep lab to confirm the optimal setting. And then just to encourage continued use. And like anyone with a new device, you want to follow them, every couple of weeks initially, just to make sure that they really understand it, they're using it, they're getting benefit from it. You can troubleshoot any issues early on, because early on is when they're either going to keep working or they're going to give up. So early on, you really want to do that phone call the day after they turn it on. You really want to do, if there's problems, you want to call them the next day too. You want to get them in the office very quickly after you've turned it on. And after that, you can just start to space those visits out depending on the patient's needs. And some patients, it's been as simple as, I turn it on every night, but it's not doing anything. And you say, well, turn it on in front of me in the office. And they don't have the remote control on top of their device. And the remote has to be literally on top of their chest to work. And if it's not right there, it just doesn't work. And yes, they have been turning it, but they haven't been turning it on. So it's just the small things that need attention that will make success to your program if you pay attention to it.
Great. Audience, we are going to try to fit in just a few more questions. If you have a question, please be sure to type it into the questions box on the right-hand side of your screen. Dr. Huntley, what can be done for patients who are uncomfortable with the stimulation or just not getting therapeutic benefit?
One of the nice parts about the way that this has been designed is that the cuff that's placed around the hypoglossal nerve has 3 electrodes on it, and we can control the polarity of the electrical charge through each one of those cuffs, and it also allows us to control the some of the comfort settings, meaning the rate and the pulse width of the stimulation that's being delivered to the nerve. So patients who are a little bit more sensitive and notice stimulation at lower voltage levels, you're able to change some of those comfort settings and also able to change the configuration of each of those electrodes to optimize the way that the electricity is delivered to the nerve and the way the patient senses the stimulation. In a very similar way, if patients have a less than optimal response, we can customize the way that the electric field is surrounding the nerve and is delivered so that we can optimize the way that the tongue is contracting and responding to the stimulation.
Dr. Huntley, what is the status of insurance coverage for Nspire? We've gotten a couple of people asking about that.
I mean, I can comment. I'm in Philadelphia, so I can certainly comment on our practice in our region. It's probably a little bit regional. In our region, it's approved by Medicare, or it's a covered intervention by Medicare, and we're in the Novitas region. Also, three of our main insurers, so Aetna, the Blue Cross plans, and United, have positive coverage statements as long as patients meet all of the indications that were reached previously. The other insurers, which are a smaller proportion of our patients, we've been successful with going through an appeals process and getting coverage for. So at least in our region, we've been very successful in having it covered.
Dr. Goss, what is considered treated or success with Nspire?
So success would be two things. One would be treatment of their apnea with less than 5 events per hour on their titration study, and all of our patients have been able to achieve that. The other marker of success is adherence to therapy, that they continue to use it and benefit from it. And so far, we've had wonderful outcomes with that as well.
Great. Dr. Huntley, does a patient need to have an in-lab PSG to find out if they're a candidate for Nspire, or is a home sleep test sufficient?
I mean, I would prefer them to have a PSG. I think you get better information, but that's not a realistic expectation in today's practice environment with the insurance coverage the way it is. So a home sleep study is adequate to give us enough information and get things covered. And as long as they meet indications from that, plus all of the other data points, then we can proceed with a home sleep study.
Dr. Goss, did you want to add something to that?
Yeah, I would just agree with that, with also the advice that if you are suspecting someone to have central apneas because of a heart failure history or a stroke history, don't hesitate to get the PSG, just to make sure that you don't have someone with a high central apnea, because again, you want the patients to have success with the procedure.
Couldn't agree more.
Thank you so much. Fantastic. Well, good to end on a point of agreement, and thank you so much for letting us ask you anything. To finish on time today, I want to conclude by saying thank you to our physician panelists, our sponsor, and to our audience members. This webinar is free for attendees, courtesy of sponsorship by Nspire Medical Systems, Inc. The webinar was recorded, so you may rewatch for free anytime. The link will be emailed out to all attendees tomorrow, as well as to the folks who registered and were unable to make the event today. Please feel free to share the link with colleagues who may have missed today's live event. You may email additional questions about Nspire to Erin Anderson at inspiresleep.com. That link, that email address link is on your screen right now. This webinar was produced by Sleep Review. Visit us at www.sleepreviewmag.com, and thank you for participating in this Sleep Review webinar.